Good morning and welcome to my YouTube channel Pain Free Partha and also my website www.painfreepartha.com. Now we are going to discuss something on perioperative diabetic care. Okay, this is exactly what I can is completely not from the books. There are something from the books and there are something exactly what is practical for that case like. I wish to bring on a big salute to the legendary teacher of 2 centuries, Professor Ravi Shankar. Now, why should I choose this topic? Because what is needed for a patient and what is given actually may be a little gap in that. So that is what is. Now you see, a 60-year-old male on OHA before admission his sugar was 185. He was having a blood sugar of 185 on oral drugs. Admitted for surgery, but on admission it becomes 380. Started on insulin actrapid 6 units. And review after 2 days, it was 300. 380 became 300. Now it is increased from 6 to 8. Now you think that already 3-4 days have gone. And what is the surgery? It is cataract. So that is why we need to have a clear concept about what should be done for each case. Now we will start with the basics. What is diabetes mellitus? It's a clinical syndrome resulting from inadequate supply of insulin. Supply of insulin is less or supplied insulin resistance is more. We can have classic polyuria, polydipsia, polyphagia, or sometimes a genital itch, sometimes a trivial loss of weight, an increased appetite. These all may be the symptoms. Or there may be an incidental finding as this fellow goes, an IT fellow goes for an yearly checkup. They find out that they have diabetes. India is the diabetic capital, that there is no doubt about it. We will have 4 types. What I have understood. First is immune mediated. That is an autoimmune reaction, and there is a complete beta cell failure. They produce type 1 diabetes. Type 2 is there may be some deficiency, there may be some resistance. This is what we routinely see, where insulin resistance may be the predominant problem. It is not immune mediated. Both may need insulin. That is a different issue. MODI is maturity onset diabetes of the young. For example, type 1 occurs in young fellows. Type 2 occurs in old fellows. If type 2 occurs in young fellow, maturity onset diabetes of young, this is called MODI. Simply, I'm not going into the details of his genetics somehow. There is something called LADA, latent autoimmune diabetes. This is an adulthood type 1, latent autoimmune. It is there, but it displays or portrays its symptoms after 25. So that is, but actually the problem is immune mediation. So the third one is also secondary due to steroids, thyroid diseases. The fourth is gestational diabetes. So we have also told that insulin dependent does not matter. It is type 1 or type 2. What are the diagnosis? Symptoms? If you have symptoms, genital itch plus RBS of 250, yes, it is diabetes. Fasting of more than 126 and PLBS of more than 200, diabetes. A1C of 6.5 maybe mostly, but we need to repeat. Pre-diabetes, 100 to 125, fasting. This is what is called impaired fasting glycemia. This is impaired glucose tolerance. 140 to 199 is the postprandial. If it is more than 200, diabetes. We need to take plasma venous glucose. That is what these things are about. Because arterial and capillary blood yield glucose values 7% higher than venous blood. Whole blood is usually 15% lower than plasma values. Fasting or capillary may be vary. So these things have to be kept in mind whenever you say that this patient is a diabetes. What we say as 126/200 is plasma venous glucose. Now, a surgical problem can cause hormonal counterregulatory, catecholamine, steroids, glucagon, hyperglycemia. Okay, this is added to an anesthesia stress. So what are the treatment available? Lifestyle modifications, drugs, insulin. In the drugs, biguanides, metformin, glitazones, pioglitazone. This is peroxisome proliferated activator receptor action. Secretagogues may be sulfonylureas and non-sulfonyl. Secretagogue means it promotes insulin secretions. Agents that reduce absorption of carbohydrate like agaribose, voglibose, etc. These are all old drugs. Now, the new drugs are, we all know, gliptins, sitagliptin, itagliptin, etc. Gliflozins, remogliflozin, saxagliflozin, etc. Canagliflozin, empagliflozin, imiglivin. So many others, cholesterol. Yes, we will take on to all these things. What is incretin effect? Incretin effect means this fellow, one fellow is there. We are giving oral glucose. Okay. Now the sugar is 175. There is one more fellow, B type fellow, another fellow. That fellow we are giving heavy glucose. And measuring. The glucose is 175. Now, if you measure the insulin secretion of A and B, A insulin secretion is good, but B is less because we have given IV. There we have given oral. So something happens here. That is what is called incretin. Oral glucose intake followed by a similar glycemic profile between IV causes better insulin secretion. This is called incretin effect. This is because of incretins. These incretin analogues are exenatide and liraglutide. These incretins may be destroyed by DPP4. இந்த DPP4 inhibit பண்றது gliptins. Now we have gliptins, and these gliptins can be continued throughout the perioperative period. A minimal bloating on initiation, take unconnected with food intake. This is what we want, gliptins. Saxagliptin, all these things. Sitagliptin, vildagliptin, these are all the common gliptins used. Sitagliptin and vildagliptin. If your drug is useful when unconnected with food intake, it is good for anesthesia because we are directly influencing food. No food like that. After operation, before operation. There are so many drugs which may interact with glucose, digoxin, etc. What are gliflozins? They inhibit SGLT2. What is this SGLT2 receptors do? Sodium glucose co-transport put into the body. Now this is inhibited. Sodium and glucose will go into the urine. So glucose urine, fluid gone, water will go. So this is what is important. Now if you give SGLT2 inhibitors like gliflozins, what is this called? Dapagliflozin, empagliflozin, remagliflozin. All these drugs, they are SGLT2 inhibitors. They cause glucose to go, sodium to go, and water to go, sometimes potassium also to go. So there will be loss of fluid, loss of glucose, loss of sodium. Thereby they cause hypoglycemia. These are also so many drugs where DAPA, Remo, Cana, and empagliflozins. It can be started anytime in diabetes, independent of insulin action. Because there is no question, it does not increase insulin. It does not cause insulin resistance like pioglitazone. Nothing. It causes BP less, cardiovascular is better because everything is going down. BP is less. That is why there is good profile with this. But the problem is now people are using these gliflozins because of their renoprotective, cardioprotective effect even for non-diabetics. There is a volume loss. There is a sodium loss. There is an increased urinary infections. You can see all urologists don't like gliflozins. It's a nightmare for urologists. It's very difficult to treat infections produced by gliflozins. So they have these things. And they are prone for euglycemic diabetic ketosis. Means what? The patients will have all signs of ketoacidosis, but the sugar will be 200. This is the problem with glyphosins. Again, I am telling, if you have glyphosins, they are prone for euglycemic ketoacidosis. The most important thing which we need to remember. Very difficult to assess postoperative fluid assessment because volume loss, sodium loss, potassium loss, all these things we don't want during operations. So glyphosins cause hypoglycemia, hypovolemia. So in a setting of surgery, infections, dangerous. Subtract glyphosins 3 days prior, and there is no urgency to restart. This is another message I want to give. Glyphosins, dapagliflozins, ramagliflozins, empagliflozins, all these tests preferably stop 3 days prior. There is no urgency to restart because they are ketotic. Surgery is ketotic. This is what we don't want. Glucose-associated perioperative ketosis. The most important problem is there may be abdominal pain, nausea, BP fall, normal glucose values, and there may be anion gap acidosis. Okay, all these things can come with SGLT2 inhibitors. But now you think of a setting of a laparotomy, setting of POD1, the patient is on glyphosins. Then you have a complication of subca. Then they think, what is the problem? Like abdominal pain, nausea, vomiting, BP fall, acidosis. They think we have done the surgery wrongly. It's a major hiccup with glyphosins in laparotomy. In emergency, yes, what should I do? SGLT2 cannot be stopped. So we need to monitor anion gap. We need to monitor serum ketones because they may cause euglycemic acidosis. If you measure only the glucose, gone. So we need to measure glucose, we need to measure ketones, we need to measure the anion gap. All these things have to be measured in a patient going emergency surgery on SGLT2 inhibitors. Take serum ketones. Check urine glucose. Sometimes Vande Bharat co-regions may be better. Go back to the originals. Cholesterol, a basic bile acid sequester. The most important problem with this is we need to take with the oral diet. So this is something like this. So a dead against. Okay. So cholesterol may not be useful for anesthetic purpose. Imiclimin is the drug which I use routinely. It's a good drug because it targets the problem. It targets the mitochondrial beta cell dysfunction and insulin resistance of diabetes mellitus. What I feel is it doesn't improve much of HbA1c. Maybe from 7.5 to 7.2 or something like that one. It improves insulin sensitivity and it takes a lot of time. There are very minimal side effects and there is no problem with food intake. So it can be continued, but there are no very clear evidence for this. Nausea and vomiting, there is no effect on volume and electrolytes. There is no effect on aspiration risk. Semaglutide is a human analog of native GLP-1 with minor modifications. It's an incretin. The starting dose is 3 milligram a day once a month, can increase later. So what is the most important problem here? The gastric contents are high risk of aspiration. Even the drug is taken for weight loss, full stomach. The high quality research is needed because these drugs are prone for aspiration. If you take an ultrasound abdomen, the stomach is full even after 6 to 8 hours of fasting. That is how it decreases weight. So the problem with anesthesia here, high risk of aspiration. Bromocriptine is started as an injection before meal titrated. There are other drugs like bromocriptine monoclonal antibodies. We will come to insulins. Now we all know this metformin causes hepatic glucose. It targets the resistance like glitazones. Sulfonylureas acts here. Pancreatic stimulation. Imiclimin acts here. Alpha glucosidase, voglibose, agaribose act here. Now there is porcine insulin, bovine insulin, taken from pigs and cows, but they are not the same chain as the A and B chains of the human beings. Then what they did is they prepared regular insulins from yeast by DNA, recombinant DNA technology. That the chain is the same. Amino acid sequence B and A chain is the same as human insulins. Then their digital analogues, what they did was they removed proline one acid from amino acid and they mixed one lysine. All these things were called lispro, aspart, like that. This were called analogues because they are the same amino acid chain is not there in the newer insulins. But previously, the human insulins were same that were prepared by from the yeast by the recombinant DNA technology. Now you see there are lispro as part. So short acting, regular insulin. This is what we use. NPH, ultra lenti have gone. Now we have come to degludec and glargine. This will go for 24 hours. They are peak plus insulins. Now you see lispro, glulisine, aspart, regular. See the difference between why they found out these analogs. Because regular insulin actrapate, you need to take 15 to 20 minutes prior food. And if you take insulin and if there is some phone call, we get into forget this meal properly. It's a problem. So that is why they put Lispro and 5 minutes, put the plate and have the food. That's the advantage. It's so fast acting. Now already there is a confusion. Think of mixture of regular and NPH, aspart and NPH. So many things. Lispro and degludec. Innumerable combinations, aspart and degludec. Studies have demonstrated higher incidence of problems, delayed wound healing, infections, respiratory complications in patients with diabetes. Now it comes to you for pre-op. Major or minor surgery, that depends upon not the duration of operation, whether the patient can go back to his normal diet or to her normal diet in 24 hours. It is a minor surgery. If they cannot eat in 24 hours, it's a major surgery. This is a problem of diabetes. It's not for general. If in diabetic, major means the patient cannot take food for 24 hours. Minor means he goes back to his normal diet, some food in 24 hours. This is what is minor and major. What is minor? No food intake for food intake within 24 hours. Major cannot receive. When to switch over to active insulin control? All type 1 diabetes already on insulin, yes, start continue with the insulin and control it. Over control means usually what they say is fasting more than 200. Well controlled major, we need not do. Major means what? 24 hours food intake is not normal. Well controlled. The patient is going to have hysterectomy. He may not have next day complete normal diet, but it is well controlled. So may not need to switch over to insulin. Decide on case-to-case basis. Now, if you have minor surgery hernia, get it controlled or get it controlled. But the problem is, yes, reducible hernia or irreducible hernia. Because irreducible hernia may have some gut. And this gut manipulation, the patient may not go to normal diet in 24 hours. It becomes a major surgery with regard to diabetes. We start with 6 units and 6 units check blood sugar. Yes, we cannot wait for the 3 days like an outpatient. We have to check the blood sugar in the evening and slightly increase the 8 from 6 to 8 units or 10 units. Sometimes heroin in Rajini films role is questionable. That is what my concept about HbA1c. People write a lot about HbA1c. But now I will have 2 instances. If HbA1c is 7, well controlled, plus random blood sugar is 325, will you take that? It is very common because the patient is a well-controlled diabetes, develops a perianal abscess, the sugar becomes 325, develops an injury, the RBS is 325. So we cannot make the patient unfit because RBS is 325. Get it controlled below 200 or 250. If HbA1c is more than 8.5 or RBS is 150, posted for lab coli, what happens in this case? I will tell you again. He is uncontrolled for 3 months. Then somebody goes to a doctor. He says, no, your cholecystitis, you have to get operated cholecystectomy. And at that time, what he does is he takes the tablet regularly. He is on good diet control for another 1 week and he shows his RBS is 150. It is fit only. You cannot wait for another 3 months for him to say the same things and HbA1c is to come back. Yes, the problem is if the A1C is high, they may have some organ damage. They may have some things. There's one more thing. If you have sugar of 200 in a trauma and your HbA1c is only 6, then you may think that it is a case of stress diabetes. Hemoglobin variants may be there. G6PD deficiency may be there. The patient may have hemodialysis, recent blood sugar, transfusion, erythropoietin therapy. All these things may totally change the H1C. That is very important. For example, the patient comes with bleeding, fractional curettage, or some hysterectomy. Now, yes, from 4 to 7 years become 3 pints of transfusion is given. So this case, your A1C cannot be reliable. So that is what we should keep in mind. There may be chronic complications, there may be acute complications in diabetes, impaired healing, dehydration, infections, etc. Hyperviscosity with thrombogenesis. But chronic is they may have neuropathy, especially autonomic neuropathy, coronary artery disease, renal. We know all this. Our prior sign means the neck extension is fine, flexion is fine. We need to assess the complications. The most important is CAD, nephropathy, and neuropathy. We need to take a hemoglobin, ECG, creatinine, X-ray chest, peripheral neuropathy, and autonomic neuropathy. Autonomic neuropathy is a special subject, and how to test all is a separate topic. Most important thing, put the hand in the pulse. Tuck, 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 tuck. Fix a tachycardia is a sign of autonomic neuropathy. Normally, tuck, 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 tuck will be there. There is some form of arrhythmia with inspiration and expiration. So this is not there. Gone with autonomic neuropathy. Fixed it is. Tuck, 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 tachycardia with it. If you are able to see this, then it means you are a patient, you are having a patient with autonomic neuropathy, and the problems of autonomic neuropathy are going to come. And what are those things? Intraoperative hypotension and perioperative arrest. Exaggerated pressure response to tracheal intubations. Autonomic neuropathy predisposes to intraoperative hypothermia, hypoglycemia awareness. Ventilatory response to hypercarbia is poor. Okay, postoperative, if you go, the CO2 builds up slightly. You will not breathe like that. You will not wash out carbon dioxide because your ANS is gone. So we need to talk about the nature of diabetes, the end organ damage, the duration of fasting, the time available for improving control preoperatively. For example, I have a separate thing on the K. Diabetic ketoacidosis. Whatever it is, you need to correct acidosis. We need to have ketonemia. Let the sugar below 200 or 250 for a better result, even if you take 3 to 4 hours. Where do we stand in electrolytes? That's a big headache. At home, the patient is on insulin PD. Does he check potassium daily? Daily he takes potassium and then puts insulin. No. The basis is if we have a basal potassium value, and if we start on insulin infusion, then you will develop arrhythmia or something else. You will have an idea of what about potassium in the morning. This is a major thing. It is not switch over to insulin necessary. Gliflozin stop 2 days prior. Very important. Glitins, you can continue. If the patient uses glargine and Lespro or aspart for daily glycemic mixture of long-acting and short-acting, the patient should take 2/3 of the glargine dose and entire Lespro the night before. Short-acting full, glargine long-acting 2/3 the dose before, and hold all morning doses. Hypoglycemia episodes can reduce it to 50%, then start your regimens. This is what you should do if the patient is on glargine or Lespro. If the patient is on OHA, well-controlled major need not. Badly controlled major, change. Badly controlled, you can wait, minor, just change the drugs. Insulin is not needed for all cases. So sometimes we need not change into analogues to regular. It may be there, glargine may be there. All time it is not necessary to acting to short acting tradition. There is one study which tells even 400 is okay. Now there are regimens. Now we know what is to be preoperatively, what is to be done. OHA should be stopped in the morning. Night you can give the food and all. Okay. If it is going to be short acting insulin, just give it is the morning. What we do, I will tell. No insulin, no glucose regimen. Everything is fine. Minor surgery, some scrotal labs, this thing, hydrosig or something. You don't need to do anything. Breakfast oral agents omitted, do the case under spinal or GA, and then dextrose also you don't give, and then give after 3 hours. Patient goes back to ward, take food and give the drugs. Okay. So this is no insulin, no glucose. You are not giving when putting the patient slightly into catabolic state. So even only the minor surgeries, pre-existing glycemic control is good. Need not admit these cases. Now this is one regimen. Another regimen is classic non-contract, non-tight. What we need to give is the idea is to keep little higher. Hypoglycemia is to be prevented. So that is the basis. It can be around 130 to 150. After midnight, you go. NPU. 6 a.m. you start 5% dextrose at a rate of 125 ml per hour for 70 kg. What we do is only 75 ml per hour. 75 ml per hour, and then start half the dose of insulin subcutaneously. If he is taking mixed ad, give the half the dose. 10 units, give 5 units. And at least give 100. Yes. In this way, if the patient has blood loss, start another normal sign in another case. Start giving these things. Give at least 100 ml or 75 ml. Monitor blood glucose and treat on a sliding scale. What is the sliding scale? You cannot continue for days together, and you cannot use for poorly controlled diabetes. Glucose is 150 to 200, 200 to 450, 251 to 6, etc. This is a sliding scale. You can give IV or subcutaneous. The problem is you cannot go on checking for 5 days. Sliding scale. Okay. So this is not an ideal thing. To keep plasma glucose tight, this is non-tight. Now you tight control. Glucose should be around 100 only. Improve neurological. We are not bothered about hypoglycemia. We want good healing, good result. We don't want catabolic. On the evening, you find out the preprandial sugar, and then start 5% dextrose 50 ml per hour per kg, and piggyback with 50 ml saline with insulin. And then check blood sugar. Glucose is 150. Yes, we know these things. Start the insulin infusion, increase the insulin infusion and all, so that it is around 100. A lot of regimens. 1 unit will decrease blood sugar by 25. That is what we should know. So many regimens are there. Now, intravenous insulin is preferable in hemodynamic stability, hypothermia, peripheral vasoconstriction. Okay, if the patient is hypothermic postoperative, intraoperatively, and there is a vasoconstriction, patient is on noradrenaline drip, there is no use of giving subcutaneous insulin for a regimen. There is something called GIK insulin, glucose insulin potassium. 500 ml of 10%, 10 milligrams potassium, 10 units, and start 100 ml per hour. It's very simple regimen, one side. There is something called velour regimen. They stop insulin infusion if it is low. Then 203 units in 100 ml of dextrose. This is what we feel is difficult, something like a sliding scale, difficult to increase, decrease, and all. There is something called Ram's regimen, also the same thing. Sometimes the list starts at 2 p.m. You will have to have breakfast, afternoon list. Give a reduced dose of insulin before breakfast and monitor. For example, I used to give 60 to 75% of insulin. For example, in the morning, it takes normally 15 units. Here now you give small breakfast and give 10 units. And then monitor the sugars. You don't know what that fellow does. Bubble wash. Complete problem with fluids. Ranitidine, metoclopramide, beta blockers, atorvastatin, ACE plan, stop, no anticholinergics, document neuropathies. Anesthesia consists may be high regional general postoperative pain relief. Think of glycemic profile. Low sugar is equal to high blood pressure sometimes. It can be beneficial. You have airway problem, no PONV, insulin infusions is shorter, opioid sparing is there, length of stay may be less. Yes, regional spinal or epidurals. Etomirate stable, ketamine hyperglycemic, benzodiazepines is okay. All these things are okay. Halothane inhibit, but not much of in vivo studies. Postoperatively, continue the infusions. What we are giving, 50 ml of glucose, 50 ml of this thing per hour. Continue the infusions. And then give insulins. Basal, nutritional, and correctional. What is basal? Base. What is nutritional? At the time of giving glucose, at the time of taking food. Extra attractive. What is correctional? There is 150 has become 250. Correct. Review preoperative and intraoperative records. Metabolic impact of the procedure. Presence of pain. Adequacy of oral intake. All these things without this. Don't treat blood sugar alone. 225 give 5 units. 325 give 8. Nothing like that. See the impact of pain. See the metabolic impact of the procedure. Now we will go to the scenarios. Now scene 1 is diabetes mellitus on Mixture 3070. 15 units. 0, 12. Subcutaneous PD. Random blood sugar is 194. Others are okay. Posted for gastrojejunostomy. Now you see, this is well-controlled major. Cannot go into normal. 75% of the dose you give the night before. Start a tight control regimen intraoperatively. We can give 10% dextrose at 8 a.m. and start giving mixed type. And see, and in the night, another 10% dextrose, bolus, and then give mixed type, like a food. But it is preferable to give a tight regimen of regular insulins. Scene 2, diabetes mellitus, sugar is 198, glimepiride and metformin for hernia. So give breakfast, stop oral drugs, monitor sugars, give diet next day or night, and then give glimepiride, metformin. No insulin change needed. Diabetes, OHA, gliptins, fasting, well controlled, gliptin, okay? Now it's for CABG. So it's a major surgery, all CABGs, only insulin. Convert to insulin and give a tight control intraoperatively. Diabetes with RBS of 3 years, not controlled. OHA comes for major surgery. Or it may be minor sometimes because the patient goes into food. So nowadays we have to switch over to insulin. And sometimes we need intraoperative non-tight. Diabetes with ANS involvement with OHA, well controlled. Now you see 4 hours plastic surgery affair. So major surgery or minor surgery. So minor surgery because the patient takes food in the next 6 hours. According to diabetes. Continue OHA and consider non-type intra and then give food, and you can also go for no insulin, no sugar. THA is a major case, but well controlled on OHA. Don't need to shift to insulin. Not necessarily preoperatively shift to insulin and some non-tight regimens. Go back to OHA after 1 day. So this can be done like this. The difference is we should be aware. Sometimes there are a lot of gut additions. They should have put a rice tube and complete shift of your oral is there. Then we need to give insulin non-tight regimen continuously. Elderly female and a fractured hip with random blood sugar of 385. Hip is a semi-emergency. I was never a diabetic, sir, you will tell. Now push insulin, get fast into control, collect electrolytes below 200, then start giving the case. Diabetic foot amputation, RBS of 350. But you need to get below 200 and you have to correct acidosis or ketosis, etc. The patient. You may take 3 to 4 hours for it. Lab coli, uncontrolled. Major surgery, uncontrolled. Switch over to insulin. Preoperatively. Stabilize. Non-tight regimen. Gliflozins posted for thyroidectomy. RBS well controlled. No problem. Stop gliflozin 3 days prior. Stop gliflozin. Start insulin. Non-tight. Twice a day insulin. There is no urgency to start gliflozins. Dapagliflozin, etc. Look for sugar control, complications, stop gliflozins. Talk to physicians we want. When to switch tight or non-tight. It is not necessary to store insulin preoperatively in our case. Look for end organ damage and always have an eye on autonomic nervous system.